Hello everyone, in this video, let's talk about a couple of more clinical questions. This is clinical question discussion part 2. So we have our first case here. A woman with breast cancer subsequently develops metastasis in her vertebral column. The most direct route for spread of the tumor to the vertebral column was where? So we have 5 options here with us. So we have branches of cephalic vein, branches of lateral thoracic vein, branches of the thoracoacromial vein, lymphatic vessels, and branches of the intercostal vein. Now let's look at the keywords of the first case. Woman with breast cancer, and the cancer is metastasizing in her vertebral column. So now we have to look for a way through which the cancer can move from the breast to the vertebral column. Let's eliminate one by one the options which does not apply the following condition. First, branches of cephalic vein. So the cephalic vein runs from the lateral side of our arm near the radius bone in the snuff box, and it goes upward through the deltopectoral groove. So definitely this is not a vein that is going from the breast to the vertebral column. Branches of lateral thoracic vein are also the same. They do not drain the vertebral column. Again, branches of the thoracoacromial vein do not drain the vertebral column. They drain only the thorax, the pectoralis major part, and the muscles there. And then lymphatic vessels draining into the axilla. Now, we might get fooled that since it is a cancer, there is a high chance that the cancer might have spread to the vertebral column through lymphatic vessels. But look what is happening here. All the lymphatic drainage from the breast ends up in the axilla. It does not go to the vertebral column. So this option also is eliminated. Now, finally, we have the branches of the intercostal veins. Now, remember, if you would have studied the back chapter when discussing about the vertebral bones, you should remember that the vertebral bones are supplied by the intercostal veins and the intercostal arteries. And these intercostal veins and arteries also supply the anterior chest wall and breast in women. So, branches of the intercostal vein would be the most appropriate answer. Yes, so branches of the intercostal vein. Now, we have the case 2 with us. In the process of doing an axillary lymph node dissection in a 50-year-old patient, the surgery resident cleans the space between the pectoralis major and minor muscles in an attempt to remove all of the lateral pectoral lymph nodes. Upon recovery, it is noted that the patient's lower pectoralis major is paralyzed. Now, the nerve most likely injured is. Let's look at the keywords again. The process of doing an axillary lymph node dissection. Okay, the surgery resident cleans the space between the pectoralis major and minor muscles. So at those space between the major and minor muscles, you have lymph nodes. And particularly here, they try to remove the lateral pectoral lymph nodes. Now these lateral pectoral lymph nodes, they are located towards the lateral and inferior part of the pectoralis major muscle. So with that in mind, usually in the lateral and inferior part, you have the medial pectoral nerve piercing the pectoralis major muscle. Now, this term called medial, it does not relate to the position of the nerve. It relates to the cord from the brachial plexus. So that is why it is called medial. And this medial pectoral nerve is in the lateral side and inferior side of the pectoralis major. And it obviously explains the fact why it is paralyzing the patient's lower pectoralis major muscle. So here, the nerve most likely injured is the medial pectoral nerve. Yeah, so let me read this once for you. Since the medial pectoral nerve pierces pectoralis minor to reach pectoralis major, it seems like for this nerve to be injured from trauma to the space between pectoralis minor and major. Also, remember that the medial pectoral nerve innervates the inferior part of the pectoralis major, while the lateral pectoral nerve innervates the superior part of the pectoralis major. I hope this question was clear. Here you can see this is the pectoralis major muscle in a cadaveric dissection. This is the pectoralis major muscle, and here you have the pectoralis minor muscle. And you can see the medial pectoral nerve here, piercing the inferior side of the pectoralis major. This is the inferior side, this is the superior side of the pectoralis major. You can see it pierces the inferior part. Now, moving on to the third case we have. During a motorcycle accident, an 18-year-old male landed on the right lateral side of his ribcage with his right upper limb abducted. please note abducted. In the hospital, he was found to have winging of the right scapula, which nerve was slightly damaged in the accident. So usually winging happens when a muscle is not able to contract properly and allow proper protraction and retraction of scapula. So the answer for this one is long thoracic nerve, and let me explain why. So see, the long thoracic nerve supplies the serratus anterior muscle, but in this injury, it is denervated. So the muscle can't protract the scapula, and therefore trapezius and rhomboids will take advantage and retract the scapula more powerfully, and that is why the patient's scapula will be winged backwards. So here we have the symptom for it. Now, there's another fact that we must know. The long thoracic nerve is derived from the nerve roots of C5 to C7. This nerve is particularly vulnerable to iatrogenic injury during surgical procedures. What is iatrogenic? Iatrogenic injuries are those injuries that are caused due to medical examination or treatment by mistake. Okay, since this nerve is located more superficial to the serratus anterior muscle, there is a high chance that this nerve can be damaged during medical examinations or treatments of certain kinds. Now we have our fourth case here, which is from histology. A patient has been diagnosed with a type of cancer. The cancer is present in the organ present in the epigastric and left hypogastric region of the abdomen. Which of the following tissue represents the organ and what type of cancer is the patient diagnosed with? Now remember, epigastric region is the region just above your, below your xiphoid process and above your umbilicus, right? So this is your epigastric region and left hypogastric region. So look at the tissues here. This looks like a tissue from the gastrointestinal tract. This looks like from a tissue from the liver. This looks like the tissue from the pancreas, because in the center image, you can see hepatic lobules, polygonal, hexagonal shaped like hepatic lobules. And here you can see serous and mucus acinine, islet of Langerhans cells. And here you can see a lot of columnar cells. So since this organ is present in the left epigastric and left hypogastric region, this should be our pancreas. So the answer is pancreas and pancreatic cancer. Here you can see epigastric region, left hypogastric or hypochondriac, you have pancreas in both the sides. So this is the case of pancreatic cancer. Okay, the final case for this video. A young boy, while playing football, got himself hurt when he was not able to receive the football properly. So instead of receiving the football hit the area just above the hip girdle. The boy is suffering from severe pain. What dermatome level do you think is affected here in this case? This is pretty simple. Look at the keyword here, just above the hip girdle. So what is the dermatome present just above the hip girdle? It is T12 dermatome. So T12 dermatome is affected here. And here you can see this is the T12 dermatome, just above the hip girdle. Okay, that brings us to an end of this clinical session. I'll catch you guys in the next one. Thank you.